So, we've now made the decision to start medication and done all of the preparatory work needed before initiating treatment. The next obvious decision is to decide which medication to start with. In this video, we'll be discussing how to decide which medication should be used first and how doctors and patients can manage this decision making. Then we'll think about how to measure outcomes and optimizing treatment. So, where do we start? All of the evidence agrees that stimulants will usually be your first choice medication for ADHD. This is supported by all of the major evidence-based guidelines. Choosing which stimulant to start with is, however, less straightforward, with different guidelines approaching this from different angles. There is, in my opinion, no clear right and wrong, and your choices will be based on a range of factors, including the evidence about the balance between efficacy and tolerability from network meta-analyses, the availability of different medications in different countries, local regulations on prescribing, and personal preferences of both the physician and the patient. While the network meta-analysis of Cortez and colleagues that I was also involved with concluded that methylphenidate would be the first choice treatment for children and adolescents and lisdexamfetamine first for adults, I don't think that this is a particularly strong recommendation. Indeed, several guidelines, including the recently completed Australian ones, don't prioritise one stimulant over the other. Despite a lack of true head-to-head studies, the available evidence suggests that around 7 out of every 10 people with ADHD respond really well to methylphenidate, and 7 out of every 10 respond really well to an amphetamine, with some responding just as well to both, some better to one than the other, and some to neither. Overall, around 90 to 95% of people with ADHD do respond well to at least one stimulant. While it's important to recognise that there are no clear indicators at the individual patient level which stimulant that person will best respond to. In my experience, this is really important to point out to patients before you start treatment. I hear back from some patients that their doctor has suggested to them that in their particular experience, a particular stimulant is best for people like them. These claims are not supported by evidence and actually can lead to difficulties. What if that patient does not respond particularly well to that first stimulant? You will then want to try the other stimulant. Your patient may well come back and say, well, you told me that the first one was the best. Why would I now want to try the second best? In my view, it's much better to be honest, to go with the evidence, and to say that we can't tell which stimulant is going to be the best for each individual person. And explain clearly that if the first medication does not work, not to worry, we have another one that is just as good that we can switch to. There are a few situations where one would choose to start treatment with a non-stimulant. For me, the most common is where there's significant risk of substance misuse, particularly if this involves stimulant medications such as cocaine or methamphetamine. Another is where there's a current or recent history of bipolar disorder or psychosis. Some will choose to avoid stimulants where there's a history of tic disorder or Tourette's, although this isn't an absolute contraindication. In the past, people were reluctant to start stimulants when there was a coexisting anxiety disorder, but this is now recognized to be unnecessary, as the response in this group is actually very similar to that where anxiety is not present. More important than which stimulant to start with first is how the medication is actually titrated once it is started. There are several approaches to titration. In general, clinicians are advised to start low and go slow. However, this can be taken rather too literally, and I often add, but not too slow, to avoid an incomplete titration that fails to optimize outcomes. My own approach is to aim for maximum response at minimum dose with the least side effects. While most guidelines recommend titration, few, if any, actually go into detail about how to do this. Evidence from studies like the multimodal treatment of ADHD study, commonly called the MTA, have shown us that it's possible to safely titrate over a full range of doses quite quickly. Indeed, the MTA titration used a full range of doses of methylphenidate, up to 20 milligrams 3 times a day, and did that over a 4-week period, changing doses every day in a pseudo-random order. Clearly, this is not a practical way to go about titration in our real-world settings, but with stimulant medications, a full titration over a similar dose range can usually be achieved within 4 to 8 weeks, depending on the clinician's schedule and the patient's availability. In our clinics, we have adopted a structured approach to titration, where response at each dose is measured at each appointment using one of the standard ADHD rating scales based on the DSM ADHD symptoms. For example, the ADHD rating scale or the SNAP. We aim for the lowest dose that gives the maximum symptom reduction. We also use a standardized approach to ask about adverse medication effects and feed this information into our clinical decision-making process. In fact, that we've learned that this approach is so successful that we continue this structured approach into measuring outcomes in our continuing care clinics. This measurement-based care approach has had a significant positive effect on clinical outcomes, and it's well received by both our clinical staff and our patients. Measurement-based care is becoming more common in mental health, although we have a long way to go before we can catch up with our physical health colleagues who have developed sophisticated approaches, for example, in diabetes, asthma, and hypertension. However, the International Consortium for Health Outcome Measurement, ICHOM, have just published a core set of outcome measures for neurodevelopmental disorders. You can access these outcome measures through the ICHOM website, although you do need to follow the registration procedures before you can actually download the outcome measures. This set of measures includes not only core symptom measures, but also measures of quality of life and functioning, as well as recommendations for measures that cover common coexisting problems. The measures included in the ICHOM set are all patient report and all freely available to clinicians around the world. The hope is that this core set can deliver a platform from which measurement-based care approaches to the management of ADHD can grow. So this is how we get started with medications. In the next video, Sam Cortez will discuss some of the don'ts, the things that we should avoid doing when using ADHD medications.